I can confirm we're now live.
Thank you, Jen, and welcome to any of the public who are watching or watching at a later date. I'd like to introduce myself, Mike Gibson. I'm the chair of this meeting. This is the Health and Care Overview and Scrutiny panel, and if people would go through to introduce themselves. I'm going to go through in no particular order of the screen that I've got in front of me. So, Aidan, if you'd like to start.
Hello, my name's Aidan Jordan-Lewis. I'm a transformation manager for mental health and learning disabilities. So I work as part of Nadia's team, and in Friendly, each different area has a transformation manager. And for me, I'm based in Bracknell.
Thank you very much. Nadia.
Good evening, everybody. I'm Nadia Barakat. I'm the Director of Mental Health, Learning Disabilities and Children and Young People for Frimley CCG.
Thank you very much. Pauline.
Good evening. I'm one of the Borough Councillors, College Town. I'm joining the evening panel.
Thank you, Pauline. Alvin.
Alvin Finch, another one of the Borough Councillors representing the Priestwood and Garth.
Jill Birch.
Councillor Jill Birch, I represent Hamworth, and I've got to say I've been a councillor for 21 years, so I've been a councillor a long time.
Must have started very young, just when it started legal to be a councillor at 21. Isabel. Councillor Matic.
Yes, sorry. I'm a Councillor Isabel Matic, and I'm Vice Chairman of this committee. And I've actually I was first a councillor in 1976.
Good Lord. Thank you, Isabel. Councillor Michael Brossard.
Thank you very much. Obviously not alphabetically, but Councillor Michael Brossard, Councillor for Central Sandhurst.
Councillor Gibson.
Councillor Lizzie Gibson, Councillor for Great Holland South. And I haven't been a councillor since the 1970s or anything else.
Councillor Allen.
I'm Councillor Nick Allen. I'm a member for College Town.
Thank you. Councillor Temperton.
Good evening, I'm Councillor Mary Temperton. Can you see me? No.
Just your forehead, I'm afraid.
Oh, you're lucky. Is that better? Right. Is that better? Yes, I can't see. Okay. Councillor Mary Temperton, I'm Councillor for Great Hollands North. Thank you.
And then Hema.
Hi, I'm Hema Shukla. I'm the consultant in public health at Bracknell Forest Council.
And I'm trying to work out Jen. Is there anybody I've missed out? I've got Joey Gurney as well to ask, I think. Sorry.
Joey, so I'm Jen Lawson. I'm the scrutiny officer supporting this review, and Joey Gurney is another scrutiny colleague who's observing the meeting.
Thank you very much. Right, so I think we're going to do the apologies. We have any apologies for absence?
I haven't received any, Chair.
Declarations of interest? No, I am. I'll go through that. Members are asked to declare any disclosable pecuniary or effective interests and the nature of that interest, including the existence and nature of the party whip in respect of any matter to be considered at this meeting. I'm not going to read out the whole thing. Have we got any declaration of interest? I can see no hands, so I'm assuming that there isn't. So on to the main meeting this evening, mental health in Bracknell Forest. Jen, could you introduce who's starting off? I think it's Nadia.
Yes, it is. Sorry, I was going to say, do you want me to kick off? So I've got a presentation which I will share. If it's okay, I will take myself off camera while I'm sharing because I can't see anything. And then we'll hand over to Hema because Hema's going to pick up some more local. So I'm going to do a high level view and then Hema will pick up and Aidan as well. So just bear with me while I just share
just
my
ask
screen.
If there are any questions, can I ask people to put them into chat or say that they want to ask a question? I think it's probably best if we take them at the end rather than up the flow.
Yes,
Thank you.
that would be really helpful. Thank you. So let's see if this works. Technology being technology. Right. If I put it onto a slideshow, does it work for you? You can see that, can you?
Yes, it does. That works much better because we can see the.
Having said I would take myself off camera, I don't know now how to do that outside of the screen. So I'm just going to keep myself on camera. So I've just introduced myself. So what I was going to do was just give you a quick, very whistle-stop tour of kind of the NHS long-term plan around mental health, and then kind of how we're doing in relation to that, and then some kind of more up-to-date views on how mental health is, what's happened during the COVID pandemic, and where we're seeing some of our pressures and what we're doing to try and address that. So I'm hoping that people will be quite familiar with the long-term plan, but if not, it's a rather lengthy document. But what I've done is I've pulled out a very helpful infographic that shows the deliverables, the things that we've been tasked with as an ICS and CCG to be able to deliver for our population, either at an ICS level or locally. And there's quite a lot in there. And some of you may be familiar that prior to the long-term plan, there was the 5-year forward view, which was about bringing mental health and having that parity of steam between physical and mental health. So there's a significant amount of investment that's been put into mental health services prior to the long-term plan, and continued during this last couple of years. Long-term plan sits around 10 years, and this is the first 5 years of it. And these are the kind of key headlines about improving our community mental health offer, really focusing on people with complex need and really integrating our community offer across the board rather than keeping them in silo. Crisis is a huge issue, and it's more pertinent now given the pandemic and the impact of the pandemic. So having alternative provision for people in crisis, and we have some of that, but we're building some of that up at the moment. Psychological therapies, you may be familiar with talking therapies or IAPT. That started quite a few years ago, and it's really about increasing the access to that service in terms of the population, and making sure that those people that are accessing it are continuing through, and also recovering and sort of stating that they are in a recovery position. SMI, so people with a serious mental illness, so those people with bipolar, psychosis, schizophrenia, those people are those kind of mental health illnesses are classified as significant mental illnesses. And what we do know, and this is nationally, probably internationally actually, is that people with a SMI have worse health outcomes than the general population. So for Frimley, the life expectancy is shorter for those people with an SMI of between 17 and 22 years, 17 for female and 22 for male. And that's not because they're dying early because of their mental illness. It's about how they access services and how accessible services are there for them, things like screening, etc. So there's a real big push on physical health and again, parity of people's physical health when they've got a serious mental illness. There's quite a lot around children and young people being able to access crisis services 24/7 in the community and in our acute settings. Earlier support, so support in schools and in colleges, and also about eating disorders and access to general NHS CAMHS type services. There's a bit around learning disabilities and autism, which I won't go into detail because this is primarily focusing on mental health. 111 and access to 24/7 community care. So during the pandemic, that has been sort of enacted. So we do have currently 24/7 access through NHS 111 to mental health provision for all ages. Perinatal mental health is a really biggie one, where we've got mums who are at risk of postnatal depression and being admitted to a mother and baby unit. So there's been significant investment into perinatal services. Smoking cessation, employment, those are real the kind of links with the people's well-being and the kind of, I guess, the Maslow's hierarchy of need, having some of those key wider determinants of health that really help people to stabilize their mental well-being. So physical health and things like having meaningful employment. Suicide prevention in the region, so in the southeast, we have very low rates of suicide, but of course, one suicide is one too many. So we really are working to the ambition of reducing those suicide rates, and so putting in some suicide prevention and support, which is led by our public health colleagues. Out of area placements are one that probably people will resonate with people when they see some of those headlines in the national newspapers about having to go a couple of 100 miles to get their mental health inpatient care. So where we've got inpatient beds locally, so for Bracknell population, that's at Prospect Park in Reading. Where we've got inpatients where the beds are all being utilised, there would be a need for someone who might need an inpatient admission to go elsewhere. So our ambition is, through the long-term plan, is to reduce those out of area placements to zero over a period of time. Mental health and ambulance. So we know that people don't just suffer from physical health issues, they can have comorbid. So they could have physical and mental health issues at the same time, and making sure that we've got the right provision, mental health support into ambulance control rooms and responses that we send out. So we're working on some plans on developing that. Dementia care, so there's been a big push for quite a few years around a dementia diagnosis rate, but also about making sure that once people have a diagnosis, that they get in the appropriate care. And of course, that is very, very joined up with our local authority colleagues. There's some work around standards, and there's some targeted work in parts of the country around rough sleepers. So as you can see, there's quite a lot to be doing, and this sort of has been going on against the backdrop of the pandemic. This is just our performance at a glance in terms of those ambitions and how we're doing. We've just in the process of refreshing this. So literally this week, by the end of this week, I'll have an up-to-date version of this. But the key message is that our challenges are quite significant because of the pandemic. So I'll go into a bit of our response during the pandemic and how our services have operated during this time and continue to. But absolutely, it's impacted in some of the delivery that we were actually doing quite well on pre-pandemic. These slides will obviously be shared, and you can have a look at that. So just in terms of the national backdrop, what we saw at the beginning of the pandemic and has continued, we saw an initial drop in access to services because of the lockdowns. But what happened quite quickly thereafter is that our services never stopped operating from a mental health perspective. They moved from being face-to-face to virtual within weeks, in fact, probably less actually. So none of our services were stood down, with the exception of our dementia memory services, because the nature of the patients attended couldn't be done across a virtual platform and needed that kind of face-to-face, but they all again blended and back up to face-to-face. So what we've seen is an increase over the pandemic of complexity of patients being presenting to various services. So it's not one particular service in particular. What we're seeing is a higher acuity, so people being much more unwell mentally and more complex. We've also seen people who have previously not been known to mental health services going into crisis, and we've also seen people who have been relatively very stable with mental health issues, but very stable, that have also gone into crisis. So that has been, as you can imagine, with lockdown, isolation, people being furloughed, people's businesses folding, literally overnight. So all of these things have really, really impacted people's mental well-being, whether or not they've got a significant mental illness or low-level anxiety. So nationally, we know that bed availability for our inpatients has been quite challenging. We know that people have been, when they've been admitted to beds, they've been staying across the country for a longer length of stay. And we know that the bed occupancy has gone up as well in comparison to our pre-pandemic data. We also know that nationally, the use of the Mental Health Act has increased across the country as well, and it's across Frimley that has fluctuated. Children and young people's mental health services. So I know this session is very much focusing on adults, but it's really key to sort of mention that children and young people have been severely impacted. In the last 8 years alone, and that includes the last 2 years of the pandemic, that the CAMHS referrals have doubled in 8 years. So it was already exponentially increasing, and it's probably been accelerated by the fact that we've had the lockdown, and the impact on children has been quite significant. We've got very high caseloads in our CAMHS services across Frimley. So it's a really challenging picture in terms of what's actually happening on the ground. And bearing in mind, our teams have very much been working non-stop to make sure that those services are still operating and there's no gaps in service. So currently, as sort of previously, we've seen pressures on our acute beds. So when I talk about acute beds, I mean the mental health inpatient beds. As a result, we've seen an increase number of people having to go out of area because we've got more people being admitted, and that picture fluctuates slightly depending on whether our acutes have had to isolate wards because of COVID. So that doesn't help with the bed availability. Our children and young people are, we've seen sort of growing complexity, who've been, those that are really, really unwell at sort of the top end of the spectrum are being admitted to our acute, so both Frimley Park and Wexham Park. So we're doing quite a bit around trying to help with flow in our acutes as well, and I'll kind of come on to that later. Autism and ADHD, what we saw at the beginning of the pandemic is that people who are autistic, some finding the lockdown really, really difficult, and therefore escalating in crisis and behaviours, and there's a growing need in terms of developing that provision. Our biggest challenge has been with any of this, and that was even before the pandemic, was recruitment and retention. So developing a mental health workforce at such a rate and such depth has been quite a challenge. We are doing quite a bit around how we recruit and retain staff. Burnout is quite a challenge. So again, at the early stages of the pandemic, we saw quite a lot of staff that were traumatized by some of the things that we're seeing. So that's across the whole health and social care workforce. And so we mobilized and support for the health and care workforce. And we also have resilience hubs now that are operating to support staff. Referral and demand for CAMHS, as I've said, is been a significant increasing trend and continues to be. And currently IAPT access, whilst we were doing really, really well prior to the pandemic, that kind of has dropped. And that's partly because of the complexity and people needing more intensive support than they have previously. So these are some of the mitigating actions that are currently happening. I won't go through all of them in detail. I'm sure people will be able to read through it. But we have some additional funding through the National Spending Review allocation to support some of the discharges. So, you know, to really expedite that flow through our mental health inpatients. We've really focused on our bed pressures across the north and south of Frimley. That is really about making sure that people are admitted that need to be admitted, they're there for the length of time that they need to be, and that we're kind of helping with that discharge at the back end. So we're creating that flow. And we've also looked across our trusts to secure additional bed capacity that is more local, so that we've got people that aren't going far out of the area. Crisis in the East Berkshire patch, so through Berkshire Healthcare, we have got a crisis bed, and we've got the ability to step that up. So in between our community and our acute provision. We've got the crisis bed, but there's some additional crisis bed facilities that are being secured through the north to the south of the patch of Frimley. There's been quite a lot of focus on eating disorders for children, something called ARFID, which is Avoided Restrictive Food Intake Disorder, but also our adult services have been seeing an increased pressure around eating disorders. Some of this, the final two points on this are particularly around the south of Frimley, around the 16 to 25 safe haven and acute in-reach following crisis. So just on the children very quickly, as I talked about earlier on, we've got a particular pressure on our acutes. It's mainly Frimley Park, although we do have children being admitted at Wexham Park or attending and being admitted. Once they're in the acute, sometimes it's quite difficult to discharge them because there are, for a number of different reasons. So we've currently got a weekly discharge call for those to talk through those young people and their cases and understand what is needed to help move and progress their care. So that seems to have made a significant impact. One of the things that has come out of that is actually parental support. So there are parents who are struggling with their children's mental health and being able to support them and getting earlier support. So we have early help, the Getting Help teams, and we've got some of the mental health support teams in schools. So it's really about making sure our parents have the right support, sort of safety netting them if their child goes into crisis. So we're developing a community engagement campaign. Under the suicide prevention schemes, we've got a third sector organisation called Emerge Advocacy that is currently operating at Frimley Park. It is to support young people, engaging with them and sort of distraction for those children who have either attempted suicide or self-harm or have active suicidal ideation, with a way of kind of distraction and engagement, and they kind of in-reach into the acute and follow them out into the community, and that is being expanded as we speak to ensure we've got a 7-day coverage and also that it's working across both Frimley Park and Wexham Park. The next three are really kind of key about providing some flexibility. So advice and guidance to primary care clinician colleagues and our paediatric colleagues in the acutes, where they might be presented with somebody who, a young person who is escalating into crisis, and being able to provide that advice from a appropriately qualified professional. And therapeutic respite or step down provision, we are exploring that with our mental health trusts, our acute and our primary care colleagues. In fact, we've got a meeting this week just to kind of go through that and how that would work. And also what we recognise is that we've got some longer term plans around developing and improving our CAMS provision. However, that doesn't help today or tomorrow, where we've got young people going into crisis and families that need support. So as a result, what we've done is we've got a contingency fund that's been made available to support families or a young person where they might be escalating into crisis, to help de-escalate, or also to help support discharge out of an acute. That could be used for anything. It could be kit, it could be a therapeutic intervention. In one case, and people who've heard me talk before have heard that one young person, we used it to purchase a dog, which would help them engage in therapy. So it's whatever will work for that young person, so that it kind of helps with the here and now. So that's kind of like an overview and a very, very high level whistle-stop tour about kind of some of the key things that are happening across the Frimley system. But obviously we're talking about Bracknell, and there is a certain amount of work that's going on specifically at Bracknell Place that's very targeted to the Bracknell population under the banner of that long-term plan. And I was just going to hand over to Aidan just to kind of on those.
All right, thanks, Nadia. Yes, I was going to talk around the community mental health transformation and a few of the services that touch on it. So some are NHS services and some are other organisations. So it's more around the kind of wellbeing offer and about changing the way mental health services are delivered and providing more specialist care in the community and around PCNs and the primary care. So there's a wellbeing service, which is via Berkshire Healthcare Foundation Trust. So it was a new service. It's a pilot currently being evaluated, It was set up for people that were calling the crisis line, but would be better served with wellbeing help. So they've got wellbeing advisors and a care coordinator. So they offer practical support on situational things, social challenges, housing, money worries, drug and alcohol abuse, loneliness, and general wellness. So they offer one-to-one support, and at the end of that, there's a wellbeing plan. And they do link into other services like the employment services or stress causes, and the local talking therapies and other voluntary organisations. Currently, it's an East Berkshire-wide service, but at the moment we're having a look and see if it's something that needs to be made more Bracknell-based and more of it delivered by Bracknell Place. The other one that is a new service is Stepping Stones. I think you'll probably hear more about this later, but it's a recovery college that started in September in the town centre. It's run by an independent charity, and it's an educational approach. So they offer a range of free courses and workshops for people, and they can choose through as many as few as they like, and it can give them insights into conditions and things they can help themselves with, and how to influence their mental and emotional health. So there's quite a lot available in Bracknell, and there's many avenues that people can get help. I mean, there's the social prescribers, there's the council, Bracknell Forest Community Network, Friends in Need, which is a peer support, and also Sandhurst Counselling. But there's an issue in when people present, connecting them to the right place and the right mental health service, and having someone who they can speak to has sufficient knowledge to point them in the right direction. So that's what we've been doing with the mental health community, mental health transformation. So Bracknell is quite well served for this. There's two parts to the scheme. There's the ARS roles, which stand for its Additional Roles Reimbursement Scheme. So these are basically they're expert mental health nurses, but they're working in practices. And it's a new initiative. So they've just started. So they're just having their induction now, and they'll soon be starting in a few weeks out in practices. So the whole of Bracknell will be covered by these ARS workers, and the rest of East Berkshire, I think they've got 2 in Slough and none of the other. So it's standing quite well. So they're employed by BHFT, but embedded in primary care. It's a joint funded post. So people can access them straight away when they call the surgery. They don't have to have a referral and can see them same day. And they see patients on a needs basis. So they can provide advice and triage and liaison supports with the local mental health team. And for the person involved, they can do shared decision making. If they need to go into onward services, they can facilitate that and provide some brief psychological intervention. And they also link very closely with the next team, which is MIX. So that's a new service known as Mental Health Integrated Community Service. So that's designed to improve the access to a wide range of specialist support. So this is more for people with a significant mental health problem. And for this service, you do need a referral into it. And again, it's another partnership approach with Berkshire Healthcare. There's community connectors that work with Bucks Minds and some admin team from primary care. But there's a multidisciplinary team. So there's input from psychiatrists, pharmacists, psychologists, mental health practitioner, which is a nurse, and the community connector. So it's for people with significant mental health needs that might fall in the gap between primary care and secondary care, will be too complex for talking therapies, which is the IAP services, or people that keep coming up to the GP of it and their issues aren't being resolved, or have some more kind of complex lifestyle factors. And they can offer person-centered care, holistic care, supports to transition to other mental health services, advice and guidance, and brief interventions as well. There's also some work, because historically, if you're under one mental health team, you couldn't work with another. So they've done some work, they can hold people under their team and as well work with people who are under talking therapies. So those mental health services are specifically targeted for providing interventions and treatment, but there's also work for the general population. For a lot of people who have mental health issues, they're more seen by their GP. And there's a big program of work going on to help their physical health needs, because people, especially with significant mental health, have worse physical health outcomes than the general population. So there's a program we're looking to bring them in for health checks, and to improve the physical health. At the beginning of the year, there was an outreach program where the PCN works as teams, so we're calling people on a register of people with SMI and bringing them in and conducting a health check. And that continues this year. And we're probably below where we want to be for the numbers of people. And so we're working with the PCNs and our clinical leads, and they've put together a plan where they'll be working through the registers, offering people the health checks, and they've got a dedicated member of staff doing that, looking at their physical health and carrying out those reviews. Yeah, and that's it for me.
Thanks, Aidan. So that kind of gives you an overview. I'll stop sharing and so I can see people and see if there are any particular questions.
I'm just looking in chat at the moment, and no questions have actually come up yet. Michael Bossard has raised his hand though, so I will go over to Michael. Thank you for the presentation, I should say now. Michael.
Yeah, so just right, Mike, that was an excellent presentation. Thank you very much for that. I also assume that you will actually share the PowerPoint presentation with us. Really, yeah. The questions I've got, the one question, or really two questions. Firstly, how do the 111 receivers cope with those people who actually ring up and say, I've got a mental health issue? Normally, of course, 111 is to do with dealing with medical conditions. How do 111 deal with mental conditions? And in terms of determining whether they need to go to Frimley Park Hospital or to Heatherwood or to Royal Berkshire? And also, secondly, can I ask, what is the link between yourselves and Samaritans? Are they able to share concerns that they've got with a particular person, or is it private information that can't be shared? Thank you for that.
Okay. So I was just trying to turn the video back on, but I can't seem to. Okay, no problem. I was just going to say, so in terms of your first question around NHS 111, yes, so you're right, predominantly, historically, it has been for physical health services, but there's always been a plan for that to be mobilising mental health provision and support. During the pandemic, that became even more imperative. And so we now have, so if someone rings up NHS 111 and they need either through the kind of questions that they asked or are saying I'm in mental health crisis, we have it diverts, so we can divert it to our mental health provider. So that would be Berkshire Healthcare Foundation Trust. So that's 24/7. So it goes to our crisis teams. So we have a crisis resolution home treatment team it covers the whole of East Berkshire. It's kind of based in Slough, but it covers across. And they would pick up that mental health call. Depending on how they'd kind of triage it. So if it was immediate crisis, they would go out, or they might actually dispatch, they might ask for, we've got a street triage service that runs a couple of days a week. So they might call them out, or they'll go straight out. So they'll prioritize it. And it's also available across all ages. So it would be, if it's a child in crisis or a young person in crisis, that would be directed to our CYP, Children and Young People's Crisis Rapid Response. That would also respond as well. So we absolutely have a route through to be able to access mental health services. And we're now talking about, actually, do we put mental health practitioners in the call centre? So that's part of the conversation that we're having in terms of developing that onward model. So that's the NHS 111. With regards to your question about the Samaritans, I would have to defer to my provider colleagues, but I don't know the details of it, but I do know that if there is somebody who is deemed to be in immediate threat, that there are mechanisms through which that can be flagged up and local services can be alerted, I believe. But what I will do is I'll double check that and come back with a confirmed response.
Oh, thank you, Nadia. Thank you very much for that.
So I'll take Jill next and then Isabel. Jill?
Thank you, Chair. So it's Gilbert. I've actually got a few questions. Thank you very much for that presentation, because I started writing down a question and then it was answered by the next thing.
Brilliant.
But I am going to just go back. So I'll do it in order that I put it in. I was very interested in your out of area placements, and I looked at the number, and if I may have written it down incorrectly, but you are going to give it to us. It seemed to rise from 655 to over 1,000, 1,115. Is that correct? Is that the level of actual increase?
So that is not individual out of area placements. That is the number of days. So it's counted by days, and it fluctuates. So since then it has come down. So what would probably be helpful is maybe once we've got the refresh data is to share that with you, because that is from earlier on in the last quarter.
Well, that's interesting. What interests me, and this actually is also when you're talking about young people, is actually, do those people get visits from their family or from, do they get support? Or that was my worry. I was going to ask you that. Can you explain what happens?
So again, I will just double confirm that with our providers, but my understanding is that they aren't. So we have an OAPS team, so it's abbreviated to out of area placements, who do visit, and they would be visited by their community mental health team. So they would have a care coordinator. So I will just double check that, Jill, because I don't want to say something that's incorrect. But my understanding is, yes, that they're not just out there and then left to it, because clearly an inpatient stay should only be for the period of time that's needed. And then, we want to look to discharge people back home. And if home's not the appropriate destination, because some people do deteriorate, and that's why they've been admitted. And so it might be an alternative home destination. So I will double check that.
I was very interested in the fact that you said that some of them stayed in hospital longer. Was there data about that, or is there some data you could send us?
There is data. Again, I'll have to check with BHFT. Well, they will have that data. We know that the length of stay kind of went up, and that's reflective of the complexity of people being admitted. So people are much more unwell and therefore needed a longer stay. But I understand that has come down a little bit, but I'll get that data from Berkshire Healthcare, because they'll have the most up-to-date one.
Thank you. And was one of the reasons they were staying in longer COVID and the complications around that, or was it just their mental health?
No, so when they're being admitted to a mental health inpatient bed. So it's really around their mental health and the complexity and severity of their mental health.
Oh, good. Well,
but just to say that some people that have been in mental health inpatient beds have also ended up having COVID. So what we wouldn't do is move them to a physical health bed, so like an acute hospital.
Oh, I see.
It was indicated. So they would be supported and nursed with their COVID and their mental health issues. So it's about prioritising what's the immediate thing that needs the support, but we wouldn't neglect the other side of it.
Oh, thank you. Very, very clear answers. Now I'm going to go on to children and young people. And an increase in family admissions. What are the sort of reasons? Can you give us a broad outline of the reasons? One of the things that I'm interested in, I know it's probably a little bit off-piste here, and I apologise, Chair, is suicide risk in young men. So I'm just quite interested, just to let you know, but why is the driver for the increase? What have been the problems?
So for our young people, it's been very mixed, actually. So when this was kind of brought to our attention kind of earlier on in the year, it was being badged as young people with mental health issues. Actually, when you look at it in a bit more depth, They have a mixture. So at one point we were seeing quite a lot of young people who had an autism diagnosis. So it was their autism, and because of the lockdown, missing school, some of those normal routines. So we saw quite a number of young people with autism. In fact, at one point, it seemed to be the only thing that was kind of they were presenting with, and some of those increased behaviours. Not many of them had underlying mental health issues, but their mental health had been affected as a result. It's never quite as clear cut. Some of them were being admitted for social reasons, so family breakdown, placement breakdowns, that sort of thing. And we've seen also an increasing number of children and young people with, you will have heard of eating disorders, and I talked about ARFID. Yeah, so people with disordered eating. So they don't have what is traditionally seen as an eating disorder, but they've restricted food for whatever reason as part of their anxieties, etc. Don't quote me on this because I'm not a clinician by background. So it's something called ARFID. Sorry, my daughter's just jumped into the room. And they, so we've seen an increasing number of children and young people with ARFID, and that's not just locally, that's nationally as well, regionally and nationally. And in terms of the profile, earlier on in the year, we were seeing some older teens. What we've seen is as we come back into school, there have been slightly younger children, young people. We have unfortunately seen quite a lot presenting with an overdose and quite significant intent. So it's quite a sad situation, but we are trying to make sure that we are delivering quite bespoke interventions, so they're really tailored to those young people and those families.
Thank you for that. I've just got really, I wanted to ask something. You probably think this is quite basic, really. It was mentioned primary care and secondary care. What is the difference? I don't mind an answer or something. I wasn't sure because I didn't understand what's primary care and secondary care.
So essentially primary care would be things that are like your GP services, so in the community. Secondary care are specialist services, so our hospital, our acute hospital, so Wexham is a secondary care service. The Mental Health Trust provides secondary care, so specialist support.
Okay, thank you very much. Well, thank you for those answers. That's really helpful.
No problem.
Right, thank you, Jill. And that just shows how helpful it is to have an experienced IMS fellow chair join us on this, because there is a lot of stuff that's cross-referenced. I'm going to go to Isabel and then Mary. I haven't got any other hands up. So then we're going to go back to Hema to do her presentation, and then you can all have a second crack at the whip. Isabel and then Mary, please.
Fine. This happened to a friend of mine. She was admitted into Frimley over Christmas period and eventually found something wrong with her. She had an operation, and then she was moved for rehabilitation elsewhere. And I rang her up, and she was devastated, really. Somebody had a meltdown for the simple reason they didn't even have a television in the ward. They had to entertain themselves. And as I say, I overheard a woman having a meltdown because she was just bored out of her mind. And now that cannot be helpful for mental health. It didn't happen in Frimley, but Frimley referred her on. So, and I know that was one for the family to make a, a complaint or an investigation. But, has that happened before? Has it happened again?
So, first of all, hi Isabel. It's nice to see you after so long. Is that in a hospital, so like a kind of a Wexham Park acute hospital, or are we talking about a mental health inpatient unit? So I don't know of anything specifically because I don't know the details of that, but
it's in Maidenhead.
It's in Maidenhead. Okay, it's a mental health inpatient, is it?
She was sent there for rehabilitation, and there was no, which didn't help those people who had nothing to do all day. Which impinging, as I say, somebody had.
So I couldn't answer on behalf of services, but you're absolutely right that an important part of people's recovery is about having some meaningful engagement, whether that's a kind of voluntary thing or a paid thing, or something that they're interested in. So that wouldn't be conducive, I don't think, in my personal opinion, and it's not a professional. But yeah, I couldn't really answer that, if I'm honest, Isabel. Sorry, it's not quite a clear answer.
I just felt that it was important that you.
Yeah, no, it's absolutely right.
So you can, monitor it for future reference. Thank you.
Mike,
thank you for that, Mary. Thank you for that, Isabel. And Councillor Templeton, if you would like to answer.
I can't see me, so I hope you can see me. Can you see me?
We can.
Right, okay, good. My question really is that a lot of your presentation and everything has been about crisis and people that are very obviously got mental illness, but during the lockdown and during the fact that when doctors couldn't be seen very often, has there been an increase, and how are you picking up an increase in the begin and the onset of mental ill health, like the onset of dementia that's been building up over the last 2 years and is coming? So, and what can be done about that, please?
That's a really good question, actually, Mary. So what we were expecting during some of the early part of the pandemic, we did some modelling around being able to mobilise our talking therapies and IAP services, because that's where we thought the volume would come. Actually, what seems to have happened is that people kind of really stayed at home and sort of sat on their hands and thought, and I think what has seemed to have kind of appeared is that people have kind of stayed at home and thinking that they can cope. So they haven't sought earlier support. And then all of a sudden they've realised they can't cope and they've gone into crisis. And that's probably why I've talked about crisis quite a lot. So one of the things that we're quite keen to do is really proactively, we're trying to ensure that people are accessing that earlier support, particularly through things like the Wellbeing service and through IAPT, because those are the types of services that are aimed at people with low level mental health, anxiety and depression. So that's one thing. What we also know is some of the data through our GP practices is that we're seeing more people attending primary care, so GP practices with, again, low level anxiety. So the ARS scheme, so the mental health practitioners in primary care that Aidan talked about, are really absolutely there to try and support those people with lower level needs. And it's not, and when I say lower level, I don't mean that in any disrespectful way. I just mean that it's just that kind of spectrum of need. And one of the key things that we're quite keen to do is develop the third sector offer. And I know the local authority commissions a lot of third sector organisations and work with them to make sure that, irrespective of where your mental health is, whether it's at the lower end or at the more complex end, that there is that support in the community to be able to respond to your needs. And people, we all have mental health. Sometimes it's good and sometimes it's not so good. So we all fluctuate on a daily basis. So that's part of what we're trying to do. But yeah, we didn't quite anticipate the level of complexity that we have seen. And I suspect that will continue because, as you know, some of the trauma, the bereavement, the issues around employment. Some people may have lost homes, not during the pandemic, but might as a subsequent losing jobs. All of those things affect our core and our mental well-being. So we will anticipate seeing an impact over a number of years, and not to mention the impact on children and young people.
Thank you very much. Thank you.
Okay, thank you for those questions, everybody. If you can all take your hands down, I'll just hand over to Hema Shukla.
I'm just going to share my slides. Have they come up?
Yes, they have.
Oh, good. So I'm going to also.
I'm just going to mute and stop.
Can I see then? Okay, so I'm going to just today present some of the data that we've used to look at one of the priorities in the health and well-being strategy, which is mental health. And this perhaps gives you the size of the problem in Bracknell Forest, hopefully pre-COVID, but also then what are the impacts of COVID. So if I start the slideshow. Okay, has that moved, the slides? Hello?
Yes.
Yes,
Okay.
that looks fine.
So this just gives the population mental health, so prevalence of mental ill health, and we use the word ill health to cover all different levels of mental ill health in a population. So the first, which Nadia also mentioned, is if you look at the whole population, personal well-being, self-reported well-being, where people sometimes feel anxious or have low happiness, and this comes from the ONS personal well-being survey. They do survey quite regularly, and from the self-reported, how people feel, you can estimate the proportion of the adult population who at any time feel anxious and have low happiness. So for Bracknell Forest, 20% of the population said that they were feeling very anxious in that survey 2018, and 7% had a score which showed low happiness. Which is not different from a lot of places, and nationally we also know that there sometimes it can be quite high as well in some areas. We then have within that whole population, we have those who have common mental health disorders, and this is obviously people who can have it for a longer term, and this is not self-reported. This is obviously based on some type of diagnosis, and this for 2017-18 the estimated prevalence was 13.4%, which gives around 12,800 as numbers. And when we compare this estimate from the public health modeling to what was on the GP's quality outcomes framework registers, the prevalence of depression and the incidence for the same year, you can say it quite is reflective of that. So 20%, 12% of the population, if you look at the registered population, had some sort of depression, which was registered, and the incidence, that is, new cases in that period were 1.4, so around 1,300. And then within that population, we have people who have got serious mental illness. And this again is what is on the GP registers. So these who have been registered on the GP register having serious mental illness. So it's obviously is an approximate, because there may be people who are not registered, but generally speaking, GPs would have registered them if they've got serious mental illness. And that's, we know, is normally low. It's 0.6, so around 800 people. But what we need to be aware of also is that these are not sort of singular. There will be people who may have serious mental illness, but also have got comorbidities with other mental health problems or other physical health problems. So there is always going to be people who are more complex than what this presents, but it gives us an idea about, the burden in Bracknell Forest. What we see when we look at the trends is that mental ill health is increasing. So this gives you a graph of depression on the QOF data, again, GP registers. And this is about depression which has not been resolved. So, these are people with long-term depression. And you see it has been increasing. So the black line is the England and the blue line is for Bracknell Forest. When we look at the ONS survey on self-reported well-being for anxiety, that high anxiety and low happiness, that also we've seen had increased over the last 2 years. So generally we can see that even COVID, mental ill health was increasing. And then we had the impact of COVID, and there are estimates that if you look across Southeast, around 1.4 million adults are forecast to experience mental ill health. So that's something like 15 to 30% increase over the next few years. And we know, as Nadia had mentioned, that the reasons for this are multifactorial. There's the loss of employment, jobs, anxiety about uncertainty about jobs and finances, people who had bereavement, but this bereavement has been quite unusual because of the trauma of not having being able to meet friends and family and being there with the person. So that is a very traumatic bereavement process that people went through. Obviously, there are people who somehow increase their substance misuse, so alcohol intake, smoking, drug use have increased, but not for all, but there are people who are also given up that. And then the people who were affected by COVID-19, and we have heard about the long COVID, but we also know people who were in hospital and have suffered anxiety, depression, and also post-traumatic severe disorders. And also not only people with the COVID patients, but also we know that the frontline staff are also facing some of these mental ill health. Loneliness has been a big issue, and we've heard about this in the media. Quarantine as well as social isolation has affected people at all ages, and this has increased depression and anxiety in people, particularly in young people. They have perhaps been affected more due to social isolation. And then if we look at the variation, because we know that with every health outcome there are, and every prevalence of every health condition, there are differences in where people reside, what are their living conditions, and this is just a map showing Bracknell Forest with serious mental illness by ward, and it varies between wards from 0.4% to 1.2% by ward. And the reasons for this are, we know there are risk factors which are wider determinants as well, and this is the variation of deprivation across Bracknell Forest, with the blue ones showing areas which are more deprived relative to others. The white are those who have got less deprivation relative to the average. But we also know that besides being disadvantaged, there are protective factors. So good employment, social networks, peer support, physical activity, all these not only protect the mental health of the whole population, but even people who are suffering from mental ill health, it does protect them in terms of both recovery and rehabilitation. And this is something which I think the question previously that, what if people don't have something to do meaningful, then it can lead to mental ill health. This data over here shows that people with mental illness do suffer inequalities, because normally when we talk about inequalities, we talk about deprivation, but we forget that people with mental ill health also have got physical health that they need to look after, and we need to support them to look after that. And as Nadia had said, that because of this, people with serious mental illness die due to the same reasons that other population dies, which is cardiovascular disease, chronic obstructive lung disease, all of those which are related to some of the health behaviors like smoking, drinking, obesity. So this just shows, it's a very crowded presentation, this one slide, but what this shows is where the red circles are where we can see that the mortality rates in people with mental illness is higher, and this is compared to those without mental illness, and this is for Bracknell Forest. So these gives us individual levels of inequality for mortality and other conditions for people with mental illness. And the blue box on the side shows, just as an example, is the smoking prevalence that has current smokers who smoke. So all adults, the smoking prevalence is something like 10.9%. When you look at adults with depression and anxiety, it's 13.6%. And when you look at adults with long-term mental health conditions, it's nearly twice that of all adults, which is 22.6%. So we can see that, we need to make sure that, which Nadia has also mentioned, that we do support people's physical health when they have mental illness. And from this data, we did have a workshop to look at, as we're developing the health and well-being strategy, which has been circulated, is to look at what do we need to do, deliver through the joint health and well-being strategy. And this is joint in terms of all partners. It's not just NHS or the council. We have got the voluntary sector as well, and involved stepping stones, all were in Home Start, all were involved in co-producing this strategy. And the three key priorities that they discussed in the first working group were, we need to prevent mental ill health at a population level, so support and increase protective factors. When people do fall ill, we need to make sure that we are supporting them to recover. And then those who got long-term serious mental illness, how are we supporting their physical health and their social needs as well? So these were the 3 areas that we wanted to work on. And through this, the ambition for the health and well-being priority on mental health is promote mental health and improve the lives and health of people with mental ill health. So the next slide, which is quite crowded as well, but it shows the draft outcomes, the key actions and success indicators. The outcomes can be categorized into 3 key areas. One was, how do we reduce the population risk of some of the conditions that we are seeing? So at population level, what are the protective factors and what are the risk factors which we can work on so that we reduce, and for example, eating disorders and self-harm, because these are the 2 which came up very strongly in terms of we need to address some of this. The second is when people do need services, how are we ensuring that people are accessing the right service at the right time, so they can navigate the system? How are we supporting them to navigate the system? And what is the experience, so that the experience both for the family and the person who needs the service is good, especially for children and young people. It's also the parents who are involved in it. And then the third category, as I said, is how do we make sure that people with serious mental illness are supported to be healthy, both in terms of the physical health and some of the social needs that they have. So those are the 3 categories of outcomes which are in the draft outcomes 11 that are in this slide. And I know it's quite a lot to read, and the slides I think have been shared and will be shared, so we can definitely discuss. Then based on this draft outcomes, one of the things which Councillor Dale Birch, who is the chair of the Health and Wellbeing Board, had said to me very early on, that we need to make sure that whatever outcomes we want to deliver, there are key actions and there are progress reports. So we monitor and we bring that back to the Health and Wellbeing Board every time. So we have then drafted the key actions jointly with the all the partners in terms of what are the key actions we will take. And these are some of the key actions, again, in terms of some of the things which Nadia has said, but it's about how do we plan together. And a key part of this is, working collaboratively, working with schools, working with communities, increasing the mental health awareness, and also developing perhaps a bespoke Bracknell Forest pledge to reduce mental health stigma, because that's come out very strongly, even in young people, that sometimes they feel that they cannot speak even to their peers about even if it's a low mental health anxiety, because of the mental health stigma. So that's another area that we need to look at in terms of how we reduce. And then we've come up with a range of success indicators that, what are the data that we can collect or is being collected, and how do we make sure that we are progressing both. Some of them may be process indicators, so some things that we are putting in place, but then on the long run, it's about reducing that mental ill health in population, as well as providing support. So that is, I think, my last slide. So any questions? And I'll stop sharing now.
So I'm just looking into chat to see if there are any questions. As of yet, I haven't got anything up. Michael Brossard. And then Nick Allen. That's okay.
Thank you for an excellent presentation. I must say that was very informative.
Right, Michael, can I just ask you to stop there, because I know Nick's got to go off. Do you mind if I just rearrange?
No, of course, no. I'm happy to stand back. Nick,
thank you very much
over
indeed,
to you.
Councillor Brossard. Nick.
Thank you. It's just on that last slide you showed with the success indicators. One of them was about the number of organisations and workplace signed the local mental health pledge. I'm wondering whether you're there, because it doesn't show in the draft key actions, whether you're involving businesses there, or whether that's entirely sort of public sector, schools and that sort of thing.
No, we are definitely including businesses as well. And we had a presentation with the Economic and Skills Development Partnership, and they were very keen to work with us on this in terms of supporting businesses also to think about how they can support their employees.
Right, okay. I mean, is that mainly the really big businesses, or are we talking businesses of any size?
Businesses of all sizes, because the evidence and the work done previously from the time change shows that it is very productive for and useful for all organizations to join this, and we need to support that.
Yeah. Okay, thank you.
Thank you for that, Nick. Michael, you've been patient.
Yeah, thank you for that, Mike. Really, my question revolves, and I don't know whether you can answer that. Obviously, Hema, or maybe the previous presenter, the presenter, is to do with actually those people who can access the GPs. And I ask the question because according to today's Daily Telegraph, 61% of the people can actually have a face-to-face meeting with the GP, which suggests that 39% can't. How do those people with mental health issues actually engage with their GP? What is the mechanism? Is it 111? Is it by trying to get an online communication? So I wonder if you could actually steer us in the right direction in terms of those people with mental health issues actually engaging with their GP.
That's a good question, and I think Nadia will obviously be able to answer that as well. One of the things which happens with many of, especially in case of mental ill health, is even before pre-COVID, people sometimes do not contact their GP, quite early on with their mental illness. So there's something about how do we work with the voluntary sector and other community organizations to ensure that we are increasing the literacy among the population, but also how they can signpost. And I'll give you an example, and this is again just an example. It's not the solution to the whole problem, which Nadia will be able to respond. One of our social prescribers, and I think she's coming to present to you, because we used quite a few case studies as well from our social prescribers, stepping stones, and community to bring to light, some of the issues. Her case study was about a young person who was thrown out of their home, was very anxious, and really did not know what to do. And how social prescribers ensured that they made contact with the GP, they made contact with the community mental health teams, they made contact with other services to support this young person to make sure that they have all the services and they're signposted and referred to everybody. So I think there is something about the role social prescribers and other community organizations can play, but you're rightly, that doesn't solve if the primary care access in itself. And I'll allow Nadia to talk about that.
Thanks, Hema. So I think it's very individual. So it's about however that individual wants to engage. So much like anybody from anybody else within the population. So some people we know, say for example, women who are accessing perinatal services specifically did not want to access video, but preferred to have a telephone call. Some people will want to have face-to-face, and some people will want or be happy with a video. Sorry, that's my daughter in the background. So it really is dependent on, and I think what we've got at the moment in terms of being able to provide a blended approach to primary care, people can have the option of doing things virtually, on the phone, or face-to-face. So despite the pandemic being as awful as it has been, it has brought some huge benefits, specifically around some of the access. Although I know some people will much more prefer to have a face-to-face. I don't know if that answers the question.
Yes, thank you, Chairman. Yes, it does.
Thank you very much, everybody. That's bringing us up to the close. So if you just allow me to wrap up and thank our presenters for the evidence and information that they've given us. It's been a very good meeting tonight. Jen will be following up by taking any questions and taking the answers that need to be followed up on there. We would expect to have concluded taking evidence by the end of November. So we'll be starting our draft recommendations through December to the end of the year, with a view to having them being able to be published, at least in a draft form, by February of next year. Seems like a long way away, but with Christmas, I'm sure that's moving it somewhat. I can't say how important I think it is for us to be working with our health colleagues and I'm very grateful for the presentation and from the questions from my fellow councillors. But we're going to go into a separate meeting ourselves. So thank you very much for your time. Jen, I don't know if you've got anything to add to that.
I haven't got anything to add to that. I'll be in touch to confirm the follow-up questions, and if you're happy